Hey everybody, it's been a little bit, but doing a Thrive in 5. So hope you're excited. I had a lot of really good feedback this week. We talked about laparoscopic surgery, pneumoperitoneum, and then I asked a question about robotic surgery and some interventions that you can do if you're having trouble ventilating. I got so many great responses, and I've had some issues with this lately myself. So I wanted to kind of share some strategies. I did some, kind of a little dive into the literature. So I just want to be able to talk about that a little bit. Let me go ahead and share my screen with y'all. So ventilation strategies, I want to talk specifically for robotic surgery when you're in steep Trendelenburg, basically the patient's like doing a headstand. This happens a lot in gynae surgery, prostate surgery. You'll see these kind of positioning. And so I just want to kind of discuss that a little bit. Plus, we have the pneumoperitoneum. So, what is going on? We talked a little bit about this, I believe, on Tuesday, is when, the surgeon and to be able to see for any type of laparoscopic surgery, there's insufflation of CO2 into the abdomen so that they can see what they're doing. But what it does is it's going to increase your intra-abdominal pressure. It's going to increase the pressure in the lungs. The lungs are not going to be as compliant. You're going to have a lot of airway resistance. Your FRC is going to be down, and you're going to have decreased cardiac output, decreased preload. So I know you guys are spending a lot of time in school learning about all these things. So this is basically what's going on with the pneumoperitoneum, plus we're putting them in steep T-Berg. So the diaphragm's moving up. That's more pressure to the abdomen, more pressure to the chest, less compliance. All this stuff is happening. And depending on the patient's size, if the patient has a bigger BMI, it can be very challenging to keep these patients ventilated. So this is usually kind of what happens on your monitor. You look up, you've got the patient intubated, got the patient positioned, they dock the robot, or you get them steep T-Berg, they dock the robot, and then they're ready to go. So your sats start kind of like 94, 93, they start trailing down. Your end tidal starts kind of creeping up. Blood pressure, usually okay. Heart rate's good for the most part, depends. And then you maybe have volume control mode. You're set at like 600 mil tidal volume, but you're like, my tidal volumes are like 300. Like, what's going on? I'm not getting anywhere close to 600. You've got a little bit of PEEP going at 4, and then your peak inspiratory pressures are obviously higher, 36, 37, 38. And then your FiO2 is about 60% or so. Okay. So this is kind of typically what your settings could look like. And this is kind of what you see as your patient is being tipped backwards. And you're kind of like, okay, this is not going to work. So what can you do? So obviously your first things you're always going to do, check your patient. Did the tube move? Is pulse ox good waveform? Is everything good there? Is there anything disconnected? Is it kinked? Take a listen to make sure, like I just said, the tube didn't move. They're not right main stemmed. Are they maybe bronchospastic? They could use a little albuterol. You can deepen up the anesthetic a little bit. Do they need to maybe be suctioned? Is there something maybe? So those kind of things too that you're going to, immediately just start looking at. Other steps. I actually read a pretty good article that kind of pulled some recent literature into how we can best ventilate these patients. So sometimes because that peak pressure is going to be so high, you might need to drop the tidal volume a little bit. You can also change to, we have the patient on like a volume control. So you might be able to change to a like a pressure control. So pressure control might be better. There's a really good mode, pressure control with a volume guarantee. There's another mode like assist flow that is really good. But you might have to drop the tidal volume a little bit, increase the PEEP anywhere even up to like 7 that you can even do. I usually try not to go too higher, but they did recommend about 5 to 7 of PEEP. And then as far as respiratory rate and as FiO2 goes, you might have to jack up the respiratory rate a little bit to help combat the lower tidal volume. I was reading that low tidal volumes actually can tend to increase mortality, but if you have constant good level of PEEP, it actually balances that out. They also don't recommend increasing your FiO2. They kind of want you to keep it around 40%. I've personally found in practice that is not always possible. Depending on the length of the surgery, you can get some absorption atelectasis with that. However, sometimes, 80, 90, 100% FiO2, you have to increase it to. It's just what you have to do to kind of get your sats. So like 93, 94%, and be happy there. You can also mess with your IE ratios a little bit, do like a 1-to-1 on that. And then recruitment maneuvers. So I was actually reading this, which I thought was really interesting, but they are actually saying that you should actually do recruitment maneuvers right after you intubate. So give a couple 2 to 3 nice big breaths to recruit that alveoli up so they can exchange. They say you should actually do them after the the pneumoperitoneum is inflated. Then you should do it again after they're in Trendelenburg, and then right before they dock the robot. So I thought that was kind of interesting at certain points. I'm actually going to try that next time. At certain points, you can actually do these recruitment breaths, and they're saying it'll help. You do have to be careful when you're increasing the pressure that much, though, doing the, taking them spontaneous ventilation, turning your APL valve to like 40, 50, somewhere in there, and then you squeeze the bag for about 5 to 10 seconds. You have to be careful in patients with emphysema. You don't want to blow potentially a bleb. If the patient's hemodynamic unstable, you might drop that pressure even more. Heart failure and increased ICP. You got to be really careful with your recruitment maneuvers. All right. So I hope that was helpful. And then if nothing else, I did have one situation where the patient literally was in the 70s. I could not increase no matter what I did. So we did have to undock, go supine for a little bit. And then you can also ask the surgeon to decrease the pressure. Usually the pressure is about 15. You can ask them if they can decrease that a little bit as well. All right. So I hope that was helpful. If you guys have any other things to share of stuff that has worked for y'all, please let me know. And yeah, have a happy, thriving Thursday. And I'm here if you guys need anything or have any questions.